where they're at. Some key terminology in patient-centered care. So that's going to include these four. These are the four that I want you to just kind of key in on. Advocacy, that's that hallmark patient-centered care that assists the patient in receiving the best care possible. So remember, you're their voice sometimes. So you're really going to advocate for that patient. And that's going to hopefully get them the best care, the high quality, evidence-based care. Empathetic communication is that act of communicating with someone else from the vantage point of their feelings, their values, and their perspective. So remember, we can be empathetic without being sympathetic, not feeling sorry for them, but getting on their level as far as what are their values, how are they feeling, and really empathizing with them. Therapeutic relationship is that interaction between two people in which input from both participants contributes to a climate of healing, growing, and illness prevention. So it's that trusting relationship that we're building with our patients so that we can really make a climate or an atmosphere of healing, illness prevention, and then just growing with them. And then patient navigators are those that kind of navigate that patient through the system. So if there's barriers that come up, if there's obstacles that come up, those are the people that those patients can go to navigate through some of those things so that all of their needs are really met. Health literacy, so we can define that as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services they need to make appropriate health decisions. So you're going to come across a lot of patients or family members that don't have a lot of health literacy. They're going to not have the capability of reading, maybe even speaking the same language that you speak. And so we really have to try to figure out how to get that information to them so that then when they leave the hospital, when they're ready to take care of themselves or take care of the caregivers ready to take care of their loved one, they have all of the information that they can get. So what are some strategies that we can do to improve that health literacy? We really want to make sure we're not using all that medical jargon, that we're really kind of using very layman's terms, terminology that they can understand so that when they get home, they know what to do. We also want to make sure that the patient understands their role in their health care. So if you skip down a couple, we really want to reiterate that information. We want to explain to them, and it may take several small sessions to really reiterate that information and really explain all of that information to them so they understand their role. And then they understand that they have to adhere to that role. And this might be the patient, this may be the caretaker that you're talking to. And then we really want to encourage that patient to ask lots of questions and really be involved in their care. The more you can get them empowered to be involved, the better they're going to be when they go home so that they take care of them properly. Any questions? We'll move on to teamwork and collaboration. Do a lot of delegating. So we have to remember those 5 rights of delegation. Is it the right task? Can I delegate this task to the UAP or to the LPN? Is this a task that they can perform? Is it the right circumstance? Is my patient stable enough to be able to delegate this task? Or is this a task because my patient is too unstable, I need to take care of myself? Again, am I delegating it to the right person? Am I giving the right direction and communication? So do they understand exactly what my expectations of them are? And am I performing the right supervision and evaluation? So ultimately, if you delegate a task, it's still the responsibility and accountability of the nurse to follow through with that task. Even though somebody else is doing it, we have to make sure that it's being done correctly and sufficiently and in the most safest manner.
Professor Smith, on
Yes.
that, I know that we need to know the 5 rights of delegation and so forth. Are we going to be required to apply it to like specific roles? So like, do we have to know specifically what an LPN can take on versus like a CNA and so forth?
I don't think it's going to be that specific. There are some application questions. So I think just knowing those 5 rights, like if you're reading your question and you can tell your patient is not stable, that's not something that you would want to go ahead and delegate. I've tried to make it pretty clear cut, but yeah, you're definitely going to have to know application. But do I want you to know the exact role of LPNs and UAPs? No, I just want you to be able to know if I can visualize this patient based on my question, am I okay to delegate tasks based on what I know?
Okay, thank you.
Okay. All right, so different communication techniques that I want you to be aware of. And we've talked about these cross-monitoring. So that's when a lot of active listening is happening between team members to make sure that correct and incorrect information is getting verbalized or not verbalized. And that really helps allow those members to correct anything before something bad goes wrong. So we're really just a lot of active listening with that cross-monitoring. Call outs asks for help from each of the team members. The 2 challenge rule is that second attempt to make a concern verbalized if the first attempt goes not unacknowledged. So again, if you have a physician that a nurse is talking to and you state a concern and you really don't get anywhere with that concern, you need to challenge that physician again. So that's what that 2 challenge rule is. So make your concerns known again. CUS is that concern, uncomfortable, and safety. So that's the verbiage that you're going to use with that CUS. So you're advocating for your patient by saying, I am concerned, or I am uncomfortable with, or I think this is a safety issue. That's what the CUS is, just basically an advocating tool. Check back and read back is verbally calling out and repeating back information to confirm understanding. So I'm going to use Amos because he's on my screen right now. So if Amos says, Professor Smith, I would like for you to start an IV in my patient, I can say, all right, Amos, I am going to start an IV. So he knows I understood him and I'm reading it back to him. So it's that check back, read back. Handoff is when we transfer responsibility either from individual to individual or unit to unit. So this can happen during the beginning of a shift where you're the nurse handing off to the patient. It could be that your patient has gone downhill and maybe you're on a unit and it needs to go to the ICU. So you're doing a handoff to the ICU.
Before we move on, can you repeat what cross-monitoring was?
Cross-monitoring is that active listening between team members. So there's some verbalization going on, and you're really just listening to each other and making sure that the correct information is being said, or incorrect information is being said, and we can stop it before something harmful happens.
Okay, thanks.
All right, interprofessional teams. So we know that this is a team of individuals who work together for a common goal. And all of those team members contribute to that well-being of the patient. You can have directly involved team members, which would include your physicians, your nurses, maybe your family members. And then you're going to have those support services. I think what we really need to remember is that everybody plays a role in our patient care. Everybody is looking out for the patient care and the well-being. So regardless of if you're the nurse or you're the physician or you're the housekeeper or you're the pharmacist, you're all part of that role and you all have something very specific that you're contributing to that patient care. All right, and the last thing we'll talk about with teamwork is managing conflict and that horizontal violence. So when we think about managing conflict, it's that lines of communication have to stay open. If there's a disruption in that communication, it really has to be addressed promptly. I think all of you have probably experienced at some point some type of conflict. And if it doesn't get responded to promptly, it just builds and it builds and it builds. And unfortunately, in the healthcare setting, the patient is the one that gets kind of the bad end of the deal there. So really address that, make sure those communication barriers are nipped in the bud really quick and they don't continue to go on. Horizontal violence is those uncivil behaviors, rolling your eyes, shaking your head, talking behind your back, withholding information that might be vital for that patient, refusing to help. Those would all be uncivil behaviors that could create some horizontal violence. And what we really want to do is refocus or de-escalate any of that so that we're bringing it back to the patient. We really want the patient to be our focus. And if it's not our focus, we've got to figure out how to escalate or refocus it back to them. All right, evidence-based practice. When we define evidence-based practice, we know it's the delivery of optimal healthcare through the integration of best current evidence, clinical expertise, and patient or family values. So you can see there on the slide, those 3 circles, those are going to be your categories of evidence-based practice. Clinical expertise, current evidence, and then those patient preferences. All right, and we did talk a lot about ethical principles back in like week 3, maybe week 4. These are the 4 that I just want you to be responsible for tomorrow. Autonomy is when we're agreeing to support and respect the rights of others and their actions. So we may not always agree, but we're letting them be autonomous with their choices and with the actions that they're making. We're going to really support that independent decision making. Trying to think of some examples here. So some examples might be that we're, again, respecting the patient's choice and action. We're not discussing patient information with anybody that doesn't need to know that. So we're really keeping that patient autonomous with their own choices and their decisions. Respect for others is respecting the rights of others to make their own decisions regarding their health care. Again, it might not be something I do. It may not be something Brooklyn does, but this patient has decided this is their choice, and we have to respect that. Veracity is that obligation to tell the truth. So if you make a mistake, you admit to that mistake promptly. You're going to get involved in any fraudulent type activity. You're always going to really go around that truth. And then advocacy is that obligation to look out for or speak for our patients or the rights of others. It may be even a family member that you're advocating for. So really providing that high quality evidence-based practice. You can do that by getting involved in communities, services, other nursing services that improve not only your nursing background, but it's going to improve your patient care that you give to. All right, safety. So when we think about safety, we think about errors. So we have to define the different errors that we have here. So when we just define error, we define that as an act of commission, which is doing something wrong, or omission, which is failing to do the right thing. So just know the difference between commission and omission. Either one of those is going to lead to an undesirable outcome for your patient. When we think about adverse events, these are those undesirable experiences in which harm does result to a person. It could require additional monitoring. It could require additional treatments or hospitalization because of that harm. Sentinel events are those unanticipated events that reach a patient that could result in death. Again, it could be permanent harm, it could be temporary harm, but usually we're going to have to do something pretty substantial to sustain their life. There's lots of different Sentinel events. So how do we get involved? We really want to make sure we're reporting them so that analysis can be done. We've talked about root cause analysis. That way improvements can be made, and then we can monitor those improvements for those Sentinel events. Never events, or I would say near miss events, are those close calls. So it doesn't really harm the patient, but it had the potential to, but you caught it in time. And then how can we avoid Sentinel events? We talked about doing like a timeout. So timeout, everybody step away from the patient. Let's regroup. Let's talk about what's going on, just so we can make sure that everything that we're doing, we're saying, we're performing is the correct patient, it's the correct site if we're in the operating room, to avoid some of those Sentinel events. And then when we think about prevention of errors, how do we prioritize those preventative measures? We're really going to prioritize them based on the most fatalities. So if we have lots and lots of Sentinel events that create this fatality, that's going to be a higher up error that we're going to start looking at to try to do some more preventative measures. All right, patient handoffs. You've seen these tools probably in several of your courses. SBAR is that situation, background, assessment, and then recommendation or response. Why do we use these handoffs? We really want to increase communication and reduce errors, right? So when we think about what is the situation in our SBAR, what information are we going to give? So we are handing off our patient to another nurse because we need to go to a meeting. So we need to let that nurse that's taking over our patient know what's the situation. What is my patient's name? What is going on with my patient? How long am I going to be gone? And how can you reach me if something goes wrong? What is the background? That's going to include past medical history. So does my patient have diabetes? Why is my patient in the hospital? What is their present illness? And then what are some current concerns that I might have? Maybe I've just placed an IV and I've just started fluids and I want her to go check my IV site in about 10 minutes to make sure everything's running fine. Okay, so that is kind of the background information and then my assessment information. So what is my assessment? Amos, I just put this IV in my patient. It's got D5 half normal saline running at 75 in an hour. I just placed it. I just want to make sure everything's running fine. Can you go check on him in about 10 minutes? So those are my concerns, and I'm telling my recommendations as to what I would like Amos to do for me. Okay, and then his response would be, okay, Professor Smith, I would be happy to check on Mr. Jones in room 12 and make sure his IV the fluids are running well and he's not having any complications from it. So then that's his response back. So that's your SBAR kind of in a nutshell. And then Team Steps is the other communication handoff, and that's that stepwise approach. You're usually going through some type of a checklist if you're going through Team Steps. All right, medication rights. I know that this was probably given to you way back at the beginning of the course, and I just threw them all in there. I'm not sure exactly which ones you talked about, but I think just knowing you have the right patient, the right medicine, the right time, the right dose, the right route, always knowing that your patient has the right to refuse their medications, and then always making sure that you're documenting in the right place. And then the last competency we'll talk about is informatics. So just making sure you know the difference between EMR and EHR. EMR is that electronic medical record. It's a one-time occurrence. So it's usually on one date, one facility, one time only. An EHR is going to be that cumulative record. So there's going to be several encounters with that one. And it's going to include things like demographics, provider notes, health problems, medications, allergies, all of that good stuff. So just make sure you're aware of the EMR versus EHR. And then computerized provider order entry, that's that CPOE. So this is that system that allows those physicians to directly transmit an order electronically. And why is that beneficial for anybody? It gets into a computer system, so it gets into that EHR. It eliminates any poor handwriting that might be occurring. The provider's just typing it out, so you're not having to figure out what he or she's written. They can be entered really into any computer at any location. So the doctor or physician just has to sign into any computer and they can put those orders in. If there's any patient issues, it's going to alert that computer system. It's going to check those orders against hospital formulary, and there's going to be a lot less delays in care. So as soon as they put that lab order in, the nurse gets the alert and they can go draw the labs. Or as soon as the medication gets put in, the pharmacy gets the alert and the medications can be prescribed. So there's a lot less delay in care with those. Any questions?
Did you say that they're going